So just waiting for people to join us. Welcome to episode 3 of the webinar series by me, Farhan Ahmed. I'm so grateful for all the feedback that I've been getting about these bite-sized sort of Facebook Live events that I've been doing. Hi Suresh, hi Christian. So I'm just going to wait a few minutes and see if we can get as many people as possible joining in, and then we're going to begin. Just a recap for people that will watch this video later on. I have your email address if you messaged me, emailed me, or popped it on the comment box. I've got a list. I am, as we speak, constructing the PDFs documents for the first 2 live events, and I will promise, along with today's live event, I will get these emailed over to you as soon as possible. So today's event, we're going to be talking about the prosthodontic classification as described by Carl Misch from 1989, and it's just going to be brief, but it's something that comes up quite a lot, and it's really important that we understand the terminology. So when we're speaking to colleagues and within our team, within our larger implant team, that we're all aware of what we're planning, i.e. what is the end product for our patient. So we'll just wait to get as many people as possible to join in, and we'll start in a few minutes, and then if we get people joining in, great, they can catch up with the rest of it. What I would ask is, any questions, please put them down and I will do my best to go through all the questions and answer as many as possible to the best of my knowledge. How's everyone getting on? Can everybody hear me clearly? Can they see me? If I can get a thumbs up, that'd be great. Thumbs up, please, if you can hear me. Nothing yet. Any thumbs up? Yep, great. That's thumbs up. Appreciate that. Thank you, Michael. Superb. Superb. So we'll just give it another couple of minutes before we start. Hi, Darren. It's good to see such a wide range of people joining in. Some people that are not dentists, some people, there's technicians, there's nurses, and obviously implant dentists as well. Brilliant, because I'm hoping a lot of this stuff is useful to everybody, and that's the way I want to, what I want to get across, that it's useful to everybody, and someone gets something out of it, and that I'm able to bring it across to you in a way that's, easy to digest and easy to process. So I'm going to make a start. So Carl Misch, 1989, prosthodontic classification. Most of you, if not all, may be aware of it. FP1, FP2, FP3, RP4, RP5. Really, really important classification, and something that I use a lot in full arch. But what we need to realize is FP1, FP2, FP3, so fixed prosthodontics 1, fixed prosthodontics 2, fixed prosthodontics 3, so that's what the FP and the P stand for. RP4, removable prosthodontics 4, removable prosthodontics 5, is a classification. Now, FP1, 2, and 3 is not just related to full arch, so it's related to single, multiple, and full arch restorations. But when I speak about it today, I will be referring to its utilization in full arch implant treatment. RP4 and RP5 is really full arch, and it's a full arch removable. But let's firstly talk about some of the benefits of a removable appliance compared to a fixed appliance. So one of the benefits of having something removable in full arch is that with a removable appliance we can give the patient a lip support. It's removable, so at night they can take it out and they're less likely to to have a parafunctional habit on something that's removable if it's not in the mouth. It's easily maintainable and from the patient's point of view, because they can take it out, give it a clean and pop it back in. Often there's a cost difference between something that's fixed and removable, but not always. So that's sometimes a reason why as clinicians or patients we choose to go for a removable prosthesis over something that was fixed. Well, what are the benefits of a fixed? Well, certainly there's a psychological benefit from having a prosthesis that is fixed. We were all born with fixed teeth, and if we lose our teeth, ideally we want something that's similar to what we had. So fixed teeth in that case. One of the benefits of having implants placed as opposed to wearing dentures is there's certainly a degree of bone maintenance if we're able to load the bone with dental implants. And comparing between a removable and a fixed, certainly there's less food entrapment with a fixed appliance compared to something that's removable. So let's just be aware that there is a distinct difference between something that's removable and fixed, and advantages and disadvantages with both. So going on to the FP1, 2, 3 terminology as described by Carl Misch. What the FP1, 2 and 3 relates to is the appearance of the tooth. Now, what do I mean by that? So if we have a full arch restoration and we are replacing just the tooth because we've not lost any bone or any soft tissue, then that would be an FP1 restoration. So all that we're doing is replacing the natural form of the patient's lost tooth. So that's an FP1. So an FP1 restoration follows a natural tooth form that the patient lost. An FP2, that tooth form is longer because that patient has lost hard tissue and then subsequently some soft tissue. So they would have longer teeth, sometimes described as banana teeth. So we're replacing the crown along with some of the root. An FP3. An FP3 prosthesis is one with tooth and some pink attached. So there's FP1, 2 and 3, and the classification relates to the appearance of the teeth, and that's what determines if something's an FP1, 2 or 3. What about an RP4 and RP5? An RP4 prosthesis is where the support and retention is provided by the dental implants. Really important. So the support and the retention is provided by the dental implants, and usually that is multiple implants with a bar supporting the prosthesis, supporting the implant. So a bar splinting the implants together and then a removable prosthesis, as opposed to an RP5. Now an RP5 is where there is some retention from dental implants, but there is also support from the soft tissue. So that's the distinct difference between an RP4 and an RP5. With an RP4, the support and the retention is provided by the dental implants. But an RP5, we're getting support from the soft tissue. And I'll come back and talk about why it's so important when we decide between an RP4 and RP5, and I'll tell you a story and some clinical situations where I've come across where a clinician has made a misjudgment and provided the patient with an RP5, but really there wasn't enough soft tissue support for them for that patient to ever have a successful restoration. That was an RP5. Really, the patient needed an RP4 or a fixed. So let's talk about FP1. An FP1, or providing an FP1 prosthesis for a patient, is very technique sensitive. What we're doing here is placing the dental implants pretty much exactly where the patient's natural teeth were. So we're placing the implants in the root form where the tooth would have been, and then we're sort of building up and restoring any hard and soft tissue. So in the short term, the soft and hard tissue will be fine, but over time that will evolve, so you want to sort of compensate by building that up. Otherwise, one of the real problems with an FP1 prosthesis long term is you get soft tissue and hard tissue changes, and which can lead to black triangles. So that's an FP1. It's technique sensitive. It often involves considerable hard tissue and soft tissue augmentation. And one of the long-term problems is potentially black triangles, but it's the most aesthetically pleasing restoration for patient, because what we're doing there is restoring the natural tooth form for the patient. An FP2 is when there's already been some hard and soft tissue loss, and you're restoring the patient with teeth that are longer, and that works well when the patient doesn't have a particularly high smile line. If they don't have they're not often going to see high up into where the junction of the soft tissue with the implants and the prosthesis is, and so you can get away with it. Moving along, an FP3. Now, an FP3 is great, works well, but one of the downsides with an FP3 is often you need to do an alveoplasty, so remove bone, to gain restorative space. So it is potentially a destructive procedure, and depending on how much bone you have to remove, it can be quite a destructive procedure. So that's one thing to note with an FP3. Often requires alveoplasty, requiring removal of bone, and that's for gaining restorative space. But in terms of its planning and delivering an FP prosthesis to patients, it's quite straightforward. You can provide a prosthesis that's cost effective, and certainly what I would say is there's certainly a cost difference between providing an FP3 and providing an FP2 and FP1 prosthesis for patients. An FP3 is generally more cost effective. It's easily maintainable, especially if maintainable and repairable, especially if it's a bar with an acrylic wrap. So that's important to know. So that's the real difference, and a distinct difference between an FP1, FP2 and FP3. Let's move along to an RP4. Now, an RP4 is, as I described, implants with a bar, usually a Dolder or a Hader bar, so the denture usually has clips. And with an RP4, you were getting the support and the retention from the dental implants. Works really well on a lower or an upper arch. So that's an RP4. An RP5 conventionally is often two implants with locators, and it clips on, clips off. But what I would say, and what we need to be careful of, is especially in a lower, is that you make sure there's adequate ridge form to provide that support. Otherwise, you often get the patient coming back because the lower denture on two locators is rocking, and during function is coming away from, is moving about for the patient, and they're just not tolerating it. So that's what I would be very wary of when offering a patient a lower denture on two implants, that you assess for adequate support available, because the retention is from the implants, but the support is from soft tissue, so you need adequate ridge form. Okay, so I don't think there's anything else that I particularly wanted to mention in terms of the differences between FP1, FP2, FP3, RP4 and RP5. It's a classification, really useful, especially when we're liaising with colleagues in the implant team in terms of what we're planning. Is something that we should be aware of and noting when we're sort of seeing a patient for assessment and treatment planning, deciding our final prosthesis from the start. So we should know before we lift a scalpel or start taking out any teeth, what are we planning for that patient? Are we planning an FP1, FP2 or FP3? And our technician is aware what we're planning. So if I could get any questions coming in, that would be great. If there's anything you think I've missed and you want me to cover in relation to the Misch classification, please let me know. I'll do my best. I'm just going to scroll through. Great to see so many people on, so many familiar faces. Any questions regarding the prosthodontic classification? Just have a wee look. I suppose what I should say is often FP1 and FP2 are metal to porcelain, and often one of the things with a metal to porcelain prosthesis is chips and difficulty of repair, patching up. That's one of the big issues with a metal to porcelain restoration. With an acrylic, an FP3 prosthesis, often you can, depending if it's individualized teeth or not, you can often just unscrew it, send it to the lab, put on a temporary prosthesis in the meantime. Usually you have that, and then after a week or so you get it back and swap them over. What I would also meaning to say is, someone's asked me, do you do locators on the right? Good question. I forgot to mention, but I want to. I never place. I will never do an unsplinted full arch on the maxilla. I will always do a bar. So I will always make sure my implants are splinted in the maxilla, and the literature supports higher failure rate of implants that are unsplinted on the maxilla. So no, I don't do locators on the upper, and actually I rarely do locators on a lower. There's certainly a degree of bias. I'm much more comfortable doing full arch fixed, and I tend to be able to push my patients towards that as a treatment option. So I definitely do a lot more fixed than a removable, and I can't remember the last time I did a locator case. Any other questions regarding the prosthodontic classification? I don't have any more questions here. What if there is no inter-arch space for a bar? Okay, what if there's no inter-arch space for a bar? Very good question. Yeah, so we know we need adequate restorative space. So if there's not enough space, we need to create space. How do we create space? Well, I'm aware of two ways. One, we remove bone, and you may say, well, what if we can't remove bone? The other, well, we can't then. We need to have adequate space for the prosthetics. And the other thing is to know, sometimes we're able to open the bite. So often patients that edentulous, they're overclosed, so we're often able to open the bite, and patients will tolerate you opening the bite by 2 to 3 millimeters. So sometimes you can gain some space by opening the bite, and another way of gaining space is following bone reduction. I hope that answers your question, Sharif. Okay, Suresh, good question. The bars I do, the bar overdenture cases, are often a Dolder bar with clips. I don't have a lot of experience of the bars that has a sleeve and it fits over. And one of the issues with these really fancy contraptions is the lab cost for something like that is equivalent to, if not more, than providing the patient with fixed teeth. So why would you do a removable when the lab bill and the potential cost to the patient is the same? Naturally, if you give a patient an option, fixed or removable, the vast majority of patients will go for fixed. So be aware of that. The lab costs for a bar is not the cheaper option. The cheaper option when we talk about something that's removable is usually just isolated to locators. Any other questions? Okay, I hope that helps, Suresh. Thanks for the question. Anybody else, any other questions regarding the prosthodontic classification by Carl Misch? It's a long-standing classification, and it's still routinely used. We teach it on our courses, but I just wanted to cover it because it's often misunderstood. I also just want to say I will be uploading this onto YouTube, and the link to my YouTube channel is on my Facebook feed. I've got another question. Can FP3 compensate for the lip support provided by. Okay, good question, Eamon. Yeah, does FP3 compensate for the lip support? No, it doesn't. Really, if a patient is needing that lip support, then they need a flange, and the only way of providing a flange is an RP4 or an RP5. You could provide a flange with an FP3, but then that's a ridge lap prosthesis, and that has its own issues. So to the answer to your question, no. If you need that lip support, then it needs to be removable. It's an RP4 and RP5, and that is decided at the treatment planning stage for the patients. And often, if they're edentulous, then you need to try them with a denture without a flange. Okay, how do you make provisionals for FP1? Usually that's Sheriff. I'll be honest, I don't do a lot of FP1 prosthesis, but the few that I have done, it's usually a pre-milled PMMA shell that we then pick the implants up, and when we do FP1 type full arch cases, we utilise digital technology. Because again, accuracy is so important, and the positioning of your implants is so crucial for an FP1, unlike not so much for an FP2, and especially for an FP3, where we're really putting the implants where the bone is. Any other questions? I'll stay on for another couple of minutes and just wait if people have. Please fire away questions. If I don't know the answer, I will be honest, I won't make it up. Thanks, Sharif. Thanks for watching. I hope I was able to answer your questions. Any other questions? Pleasure. Thanks, Eamon. I hope that was helpful. So that was just a quick run through FP1, FP2, FP3, RP4, RP5. Useful to know. I'll just quickly recap. So FP1, FP2, FP3 is a description, is a prosthodontic description of your restoration. So it is related to the appearance of the patient's prosthesis. So FP1, they've got natural form, you're replacing the natural form. FP2, they've lost some hard and soft tissue, so they're going to have longer teeth. And an FP3 is when we're restoring soft tissue and hard tissue, so they have a white and pink, so that's an FP3. So they are all fixed prostheses, FP1, FP2, FP3, and RP4, RP5 are related to removable prosthetics. And an RP4 is when the support and the retention is provided by the dental implants, and an RP5 is when the retention is from the implants and the support is from the soft tissue. So crucial to have some sort of ridge form if you're going to provide an RP5 for your patients. And also note, in the maxilla, I will not provide a prosthesis with unsplinted dental implants, so I will not do locators on the maxilla, and I actually rarely do locator over denture cases in the mandible, because I'm certainly known for doing a lot more full arch fixed, and I'm able to, push the patients certainly towards a fixed solution, and I get good results. Okay, great. Thank you everybody for tuning in. On Friday, I will do another short Facebook Live, and I plan to go through the ideal features of an FP3 bridge, and I will also go through the ideal surgical steps. I wrote it down here somewhere. Ideal surgical steps to get a successful FP3 bridge. So I'm going to be talking about what a ideal number of implants, size of implants, inter-implant spacing, restorative space, etc., etc. And I will also talk about what are the features of the bridge that I will conform to get long-term good results. So I'm hoping to do that on Friday again. It'll just be a short presentation. Thank you to everybody. Have a great Tuesday. I hope everyone and their families are safe. Take care. Thanks. Bye-bye.